opportunity for me to present this presentation. So could you, sorry. Okay. Okay, I cannot. Sorry. Okay, so let's start. I'm going to talk about the relationship between metabolic syndrome and stroke incidence. So as an outline, I would like to show you this is that I'm going to talk about the epidemiology, risk factors, pathophysiology, diagnostic criteria, and how could metabolic syndrome impact stroke attack, and also how the treatment will be. So, oh, sorry. This metabolic syndrome, or we call it METS, refers to a clustering of cardiovascular disease risk factors who underlying pathophysiology that may relate it to insulin resistance. And this METS is also associated with an increased risk for some common cancers. So basically, this METS consists of constellation of vascular disease factors and metabolic abnormalities comprising, for example, the central obesity, the atherogenic dyslipidemia, and high blood pressure, and also hyperglycemia. So this cluster is highly interrelated factors appears to increase the individual's risk of vascular disease by promoting the development of atherosclerotic vascular type diabetes. For us to have a big picture of it, but actually now is 1 from 4 to 5 adults had METS in all over the world. But you see this interesting picture. This, if you see on the left side, the younger person into the, oh, sorry, not yet. The younger person into the older person. The younger you are, then you see the higher risk for men to have the metabolic syndrome. But the older you are, then the woman will have the higher risk for somebody to have the metabolic syndrome. But you also have to remember that it is very important to recognize that METS is a syndrome. This is not a defined uniform entity. So the risk factor actually is someone to have the high TG, the low HDL, the abdominal adiposity, blood glucose, hypertension, insulin resistance, prothrombotic state, oxidative stress, and also inflammation. So if you have this kind of condition, if you have all of the factors, then it's going to be very easy for you to have these associated diseases. For example, the neurological disorders, PCOS, cancers, cardiovascular disease, type 2 diabetes, stroke, or even NASH. How that happened? I'm going to show you the picture. It's actually very, very simple picture just to show you how the METS would increasing the risk of having the cardiovascular disease. So it actually is just for clinical practice. So based on this one, the many organizations have used different diagnostic criteria that may respond to two conceptual approaches. The first one approach focus on the pathogenesis of METS, considering insulin resistance as a common physiological abnormality that can lead to clustering of mentioned metabolic risk factor. And the second one is approaching to respond to a more pragmatic view and has the proposed to identifying people at higher long-term risk for atherosclerotic vascular disease who may deserve clinical intervention to reduce vascular risk. So this one goes to the insulin resistant approach. If you see for someone who have a high BMI or high central adiposity, then that people will have the insulin resistant. And this insulin resistant will have someone to have a higher insulin in their body. And that hyperinsulinemia will cause this condition, will cause alteration of glucose metabolism and also alteration of the uric acid metabolism, dyslipidemia in hemodynamic, and also other risk factor which is not traditional. So based on this one, we know the glucose intolerance for someone who has the central adiposity will be higher. And also for uric acid will be increasing, and also the clearance will be decreasing for someone who have hyperinsulinemia. And what kind of dyslipidemia that will happen in this kind of person? The first one is the increasing of the triglyceride, and also the decreasing of the HDL, and increasing of the small dense LDL. And also for the blood in hemodynamic that will cause the SNS activity will be increasing. There is natrium retention will be increasing, and also hypertension will be increasing as well. And another risk factor, which is we call the novel risk factor, such as the CRP, the PI1, and also fibrinogen will be increasing as well. And based on these factors, that person will lead into the coronary heart disease. So as I mentioned before, based on the approaching, we'll have a lot of definition goes to the metabolic syndrome since 1998. So we don't have to be confused actually. So this is the first one I'm going to show you for the International Diabetes Foundation because I'm an endocrinologist. So based on the hypertension, hyper-TG, reduced HDL, and fasting hyperglycemia. If we go for the blood pressure, it goes for above 130 over 85, or previously diagnosed as hypertension, as right now is having treatment for that. And also for hyper-TG is above 150 or on treatment, or reduced HDL for males is below 40, and for females is below 50 or on treatment. And also also hyperglycemia is above 100 for fasting blood glucose, or previously on treatment or diagnosed as diabetes. But right now, the many organizations try to harmonize this characteristic or diagnostic criteria of metabolic syndrome. As we see now, we do have the joint statement of the IDF, of the National Prevention of National Heart, Lung, and Blood Institute, American Heart Association, and World Heart Federation, and International Atherosclerotic Society, and also for the Society for Obesity. Now they go for the same mindset for the metabolic syndrome. So the category will be consist of the elevated of waist circumference, and this one is so based on the populations, and also elevated triglyceride, or in drug treatment, as I mentioned before, is also still the same, is above 150 or above 1.7 in millimole. And also reducing HDL is also still the same like the IDF before, 40 and 50 for female. And elevated blood pressure, and this one is still the same, 130 over 85. And also for the elevating fasting blood glucose is above 100, and also low HDL is above 100 will be defining the metabolic syndrome. And as I mentioned before, that if we're talking about the waist circumference, then we're talking about the populations. So based on the IDF, we're talking about 84 and 80 for women. And as we are in Asia, then maybe we can use this one, the Asian, including Japanese. This one is from IDF. It's actually for men is above 90, and for women is above 80. This is what we use because I see all of us is Asian, if I'm not mistaken. So right now, we're also going to talk about what how this
Doc,
matches
sorry
stroke
for
attack.
interrupting. Can you please
Yes.
make the slide your slide as a slideshow because they cannot see clearly about the slide. Is it possible?
Oh, I'm sorry. I thought this is a slideshow. I'm really sorry.
Thank
Okay. I'm going to use this one then. Okay, this is better.
you. Yep. Thank you so much.
Oh, sorry. Okay. Okay. This is the mechanism related to the metabolic syndrome and inflammation that are proposes to underline the development of atherosclerosis, stroke in various sites. So if you see for someone who's still in a very healthy condition, there nothing happened. But when the disease onset is starting, now they're going to be the lipid core is fulfill the tunica intima in the in the vessel, in the blood vessel. So it's also loss of cushioning function by the stiffening. So the tunica media getting more stiffer and stiffer. And more the more advanced of the onset, then the symptom is getting there. So the inflammation is getting higher and higher. So we see the tunica intima is getting thicker, and also the metabolic abnormality is getting higher. So what happened is the arterial distensibility is reduced, and the inflammation is also increasing. And so this is what happened. The antioxidant activity is reducing, and the metabolic abnormality is getting higher. So the atherosclerosis progression is higher and higher. So this one, if someone to have the stroke, and this is what happened for someone to have the stroke. This one, I'm sorry, this is maybe not so this is not so very good picture, but I think this is very good to explain what happened for someone who has metabolic syndrome and having the stroke lately. That for as I mentioned, this is the insulin resistant for someone in metabolic syndrome. And for this one, it means the oxidative stress is getting higher, and bioavailability is reducing, and the activation of kappa B and also AP1 is getting more active. And because of the renin angiotensin, the retention of sodium is getting increasing, and also the activation of the sympathetic. So this one will cause the hypertension for someone who has the metabolic syndrome. And for someone who has metabolic syndrome, as I mentioned, the inflammation is increasing. So this is causing the endothelin, oxidation LDL, CRP, and cytokine is getting increasing, and the TNF alpha interleukin in also for the interleukin 1. And for the endothelium, will cause the smooth muscle tissue, more constriction, more hyperplasia, more hypertrophy, and also easier to do the migration into the tunica intima. And based on the thrombosis, also going to be alteration on this one, increasing of the PI1, increasing of the tissue factor, and also endothelin. And this one cause the atherosclerosis. It's a lot easier to someone who has metabolic syndrome happen. And this one also make that person who has the stroke a lot easier. And what we should do if we have someone who has the metabolic syndrome. And this is what we certainly have to do, the lifestyle modification. Weight reduction is the most important thing, because we know, as I mentioned before, that waist circumference or the BMI is playing a very important role in someone who has the metabolic syndrome. So it means the weight reduction is playing very important role for someone who has the METs. So what we need to do is caloric restriction, increase physical activity, and also behavior modification. For physical activity, the WHO recommends 150 minutes per week for adults, or 60 until 80 minutes for daily activity, at least 30 minutes. And the activity also, we have to do it gradually. As we know, it's not easy for someone who has obesity to do the physical activity. Just do it gradually then. And for some high-risk patients should undergo formal cardiovascular evaluation before initiating an exercise program. So if someone who has obesity, don't start the physical activity rigorously, but we need to evaluate first about the cardiovascular. And physical activity could be formal exercise such as jogging, swimming, or tennis, or routine activities such as gardening, walking, and also house cleaning. This is some example to do the aerobic exercise. This is the moderate, and this one is the vigorous. We not recommend you to do the vigorous. We just recommend you to do the moderate. And this is also if you don't have time to do the daily basis exercise, then you can do the 3 days per week exercise like gym, lifting weights, and this one more to do the muscle strengthening exercise. And this one also important to do is a bone strengthening exercise, and you can do it 3 days per week. So as I mentioned in the 2 previous slides, that it's not just the formal activity that you can do for exercise, but you can do also in daily basis activity. So try to make physical activity as a part of your life. So for example, at home, you can try balancing the stretching while watching TV or brushing your teeth. So it's quite easy actually. You can do it at school, you can do it in the community, and also you can do it at work. For example, use the stairs instead of elevator, and go with the public transport. But right now, if you're talking about COVID, maybe it's quite difficult for us to do the public transportation. So now we go for the obesity medication. Do we need to do that? Yes, actually. We need to consider weight loss drugs if the BMI is above 27 or above 30, if that person doesn't have any kind of complications. But you can start earlier, 27 for the BMI, if that person has like obesity, hypertension, cardiovascular disease. So you can start the drugs losing weight earlier. And what kind of drugs? This is one example that we can use, like absorption inhibitors, for example, orlistat. And also, if the BMI is too high, then we can use the bariatric surgery. And this is interventional surgery that we can do for patients with the BMI above 40 or 35 with the comorbidities. So this is a kind of drugs that we can use to do the treatment for people with the meds. This is for someone who has diabetes. You can do the metformin, so the TZD, acarbose, GLP-1 agonist, and also DPP-1, DPP-4 inhibitor. So this one is the targets. We can reduce the hepatic glucose production. By TZD, we can aiming the PPAR gamma receptor agonist. And for doing with the acarbose, we're trying to reduce the postprandial hyperglycemia. And if we are using GLP-1 agonist or DPP-4 inhibitor, then we're aiming also postprandial hyperglycemia. So for the hypertension, we can use the ACE inhibitor, angiotensin, ARB, adrenal receptor agonist like doxazosin, and also like centrally acting antihypertensive. So for the hypolipidemic, we can use the statin. So this one is the target. We can use for the ACE, we can aim the ACE endothel, and also for the ARB, and blockade the alpha receptor, and also reducing the sympathetic nervous system. And for the statin, of course, we try to block the enzyme, which is enzyme of the HMG co-reductase enzyme inhibitors. So they're trying to reduce the LDL. And what kind of drugs that we can use for anti-obesity? I mentioned before, one of them is orlistat. By giving the orlistat, the target was the gastric and pancreatic lipase inhibitor. And by doing this, we're trying to lose the weight and also decreasing the insulin resistance and also trying to improve the dyslipidemia. We also can use the sibutramine and rimonabant, sorry. And for someone who has the platelet disturbance, we can use the aspirin. And also some of the patient, we can add like omega-3 for someone to have the food supplement to reduce the triglyceride and try to increase the HDL. So this is something that actually this is not my competence, this is not my really competence, but there is a retrospective analysis to use the intravenous arginine. This one is the response based on the age. So the age is more beautifully if the age is around, it's still around above 20. Sorry, below 20. So this is also the potential treatment approaches in METs. As I mentioned before, the TZD actually is one of the drugs that we can give for someone to have stroke. Actually, we can reduce the insulin resistance and also we can prevent the stroke for someone who has METs. So by this one, recently, pioglitazone has been shown to reduce the combined secondary endpoint of all-cause mortality, MCI, and also stroke compared with all placebo on top of glucose lowering and also antiplatelet and antihypertensive and lipid altering therapies. So pioglitazone actually is one of the drugs that we can consider to give for someone who has METs. And also this one is proven that glitazone, pioglitazone for specifically, is going to doing the cytoprotective in acute cerebral ischemia. So it's really good for someone who has stroke, ischemia stroke. So this is based on the Boehm and the circulation on the 2017. They said that behavioral modification for someone who has stroke and METs actually is really, really important, especially for doing the primary prevention and also secondary prevention. The first is doing the diet, exercise, weight control, and also the most important thing, don't forget the smoking cessation. And the diet, we can use the DASH, Mediterranean, AHA, and USDA diets. Try to decrease the sodium intake and also the sugar and the calorie intake. Try to, as we have to count individually the patient who has stroke and how much calorie that they can intake. And exercise I already mentioned before. And the weight control, we don't have to reduce the weight for someone into the ideal weight, but at least we reduce 5 to 10% of the first weight that they have. So this is my conclusion. It's going to be my last slide. The metabolic syndromes refers to a clustering of the cardiovascular disease risk factors. And METs is a growing epidemic throughout the world. Approximately 5 adults in every 5 has metabolic syndrome. So it's really important. And the presence of METs has been associated with an increased risk of prevalent stroke. And the treatment consists of healthy diet, physical activity, and medication of the underlying disease. So thank you very much for your attention. I hope this is going to be a good presentation for you guys. Thank you.